In this lecture, we're going to talk about single subject designs, and the reason we're devoting a whole lecture to this is because they're used quite frequently in speech-language pathology literature, because we simply don't have the numbers of people to conduct group designs for certain populations. AAC is a great example of this. So single case designs, also called single subject designs or time series designs, meet the following criteria. They observe a series of behaviors across some period of time. There is some control which permits a cause-effect conclusion, which makes this different from a case study. It is considered quasi-experimental, and we have withdrawal designs and the better multiple baseline design. It's different from a case study because of that attempt at controlling the variables, which we'll talk about here in a minute. So single case designs are based on the most basic A-B design, where A equals the baseline phase and B equals treatment. So because of the nature of the withdrawal design, so you gather some baseline data, you give a treatment, and then you withdraw it, history and maturation are ruled out by demonstrating that the behavior change occurs only with the introduction or withdrawal of treatment. The more times you can replicate that A-B series, the less likely maturation and history are causing the effects. So typically you want to see more than just a simple A-B design, at least A-B-A-B. So here's an example of an A-B-A-B design. You see in A1 we have on the x-axis tantrum episodes, and on the y-axis it's time, so that's over weeks. So they collected baseline data over several weeks, and this child was producing a lot of tantrums, and let's say this was over the course of a school day. In the B1 period there, you see, and that's over several more weeks, the intervention was introduced, and maybe this was some kind of reward system, what have you. When the intervention was reduced, those tantrum episodes went down. When that intervention was taken away, we see in A2 that those tantrums increased again. When the intervention was introduced once more in B2, those tantrums again decreased. So that pattern demonstrates that the intervention was the cause of the decrease in tantrum episodes. So when should a withdrawal design be used? And this is important. First, there has to be a clear functional relationship between the independent and dependent variables. So that it might be easier said than done, but we have to be pretty certain that, for example, in that tantrum example, that if we do this intervention, tantrum should go down, and it's not caused by any other thing. So when we can also use a withdrawal design when the nature of the target behavior is such that it can be reversed when the treatment is withdrawn. And this is probably the most problematic item for speech-language pathology interventions, because a lot of what we do, we want our intervention to stick. So, for example, if we're teaching a student a reading strategy, we want them to be able to use that strategy even when we're not there, when we're not scaffolding their learning. So their independent use of that is the goal. And that's the case for a lot of what we do in therapy. And so you really can't withdraw what you've taught them. So if that is the case, this is not the right design for you. And so in the third bullet here, when the nature of the treatment is such that its effects are not present on the target behavior after it's withdrawn, is very similar so to the second bullet here. So again, there's certain interventions that you just can't take away without some kind of effect on the individual. And finally, we certainly have to think about ethics when we think about withdrawing something that's working. So for a lot of what we do, if we see in baseline that a child is struggling with something and then we provide an intervention that works, it might not be ethical to then withdraw that intervention for several days or weeks, what have you, just to collect that data. So you do always consider ethics when you're thinking about which design is best for your research. So when is this inappropriate? This is kind of the opposite of the last slide. So if the target behavior is not reversible, you can't do this. And when, in the same light, when the treatment effects will continue after the treatment is withdrawn, this is not the right design. If it's not educationally or clinically desirable for the behavior to return to baseline levels. So let's say we're trying to teach a child who uses an AAC device not to throw his AAC device, and we're doing some kind of intervention that's going to support that. And let's say it's working. It's not very desirable to go back to baseline when that device is thrown. So that would be a reason not to use a withdrawal design. And then, of course, the last bullet, when the target behavior is such that withdrawal of effective treatment would be unethical, we really don't want to use this design. Okay, so a better design that I think you'll see probably more frequently in the literature is what we call the multiple baseline design. It is definitely the most appropriate form of the single case study design because it doesn't require withdrawal and it avoids ethical concerns, and it can be used with a variety of types of treatments. So it solves some of the issues that we've seen discussed with the withdrawal design. So we'll spend a little bit more time on this one. So what exactly is the multiple baseline design? Well, it's an A-B design still with that baseline and treatment series, but it's replicated within the same study. And there are three major types. So you can have a multiple baseline design across settings. So the control would be, can the student do this skill or use this behavior that we're teaching them at school, at home, in the community, for example. Probably the one that's used most frequently is a multiple baseline across participants. So even though this is called a single case design, we could have more than one person, and that trips students up a lot. So we do see this most frequently, so we might see the same treatment being used with at least three or more participants. And we'll talk about how you design this so that you add the element of control. Finally, we have a multiple baseline across behaviors. So let's say we're trying to extinguish some negative behaviors from a client, and we're using a single intervention approach to address hitting, spitting, throwing, let's say. That would be across behaviors. So how does this work? The researcher first takes repeated measures of baseline performance concurrently on two or more baselines. So typically what we want to see, and we're talking about with the baselines, we're talking about across settings, participants, or behaviors. We want to see at least 3 data points at the baseline phase. And we want to see that across Sally, Joe, and Johnny, if we're talking about across participants. Okay, and that is the dependent variable, those behaviors or whatever we're trying to measure. Once a stable, predictable baseline is obtained, and so we want to make sure that, if we're talking about using your communication device to request, say, that we want to show that the child isn't already doing this. So we shouldn't see a lot of requests with the device at baseline so that we can show some improvement. Once that predictable baseline is obtained, so that could be 3 data points or more until you see more of a flat kind of trend in the data. Then, if we're talking about multiple baseline across participants, we would start the intervention for the first participant while keeping the other 2 or more in the baseline phase. Okay, those baseline conditions are maintained until we see a trend in that first participant or setting or behavior in intervention. So we want to see an upward trend of improvement or decrease, if whatever the desired behavior is. All right, and I think this next slide can help explain this a little bit better. So here, so what we see here is this vertical line, okay? And this is a multiple baseline across 3 behaviors. This vertical line is what we call a staggered start. So what you see, behavior 1 is kept in baseline for at least 3 data points. And here we have 3 data points and the behavior is really low. So let's say this is requesting with the device, this is commenting, and this is, using please and thank you or something, okay? And we're using a certain intervention to address all 3 of these behaviors. So we see that the child is not really using those skills consistently. They're not using it very often. So in baseline, we see pretty much a trend here. So once we get this trend, this behavior is not occurring, then we can start treatment for the first behavior, which in this case was requesting. So we start treatment, we see hopefully an upward trajectory change. And here the researcher said, okay, that the change is noticeable, and so now at that point I can start treatment for the other behavior. And then right here, after keeping this one in baseline the whole time, now I can treat this behavior. And what this staggered start does, it adds the element of control. Because now you can say, once the treatment was provided, there was an increase in the behaviors, the desired behaviors in every time. So that indicates that it must be the treatment that is causing the change in behavior, because we have controlled by keeping the other behaviors in baseline. So this same setup would work if we had participant 1, 2, 3, or setting 1, 2, 3. It doesn't matter. But like I said, most often we'll see this with participants. So this would be Johnny, Jane, Joey. Now, I think you might be thinking about some issues with this. And probably the most problematic issue is the amount of time you have to keep a behavior or setting or a person in the baseline phase. So here, if this is days, that's 10 days that, let's say, Johnny wasn't receiving any kind of treatment and you're just probing and collecting data. If this was weeks, that's a really long time. So that could be problematic, and it's a lot of work on the part of the researcher to collect that level of data over this time period and seeing these people so frequently. So that could be a consideration. Also, you have to be able to isolate behavior or some kind of target. So for example, I would love to use a multiple baseline design with some of my pragmatic language intervention, but I have a really hard time isolating certain skills, like conversational skills, in a meaningful way. So what I mean by that is if I wanted to do a multiple baseline across participants, and I wanted to do something with conversation, I'd really have to isolate some conversational skills. So maybe it's introducing a topic, maybe it's using nonverbal cues to demonstrate your understanding or that you're listening. But I have a problem with just isolating those skills, because when you scale that back up to conversation, so what if you're able to initiate and then you can't maintain, or you can't close out a conversation, or so what if you can show that you're interested but you have nothing to say? So for certain things, I think a more comprehensive type of intervention approach is warranted, and in those cases this isn't probably not the best design. So even within multiple baseline designs, we can think about effect sizes, but it's different than Hedges' G or Cohen's D, and that's really important. And this is kind of a newer idea, which is exciting. So Schlosser and Wendt are nice resources for looking at the different effect size calculations. In this class, we're going to talk about just two of them, but that should be sufficient for most of what you see. So why should we be calculating effect sizes? Well, single subject designs were traditionally evaluated by visual inspection of the data. And when you look at the research studies you find, you might see that based on visual inspection of the graphs, it was clear that the treatment was the cause for the change in behavior. And that is okay to report, believe it or not. It seems kind of sketchy there. But if we go back to the previous slide, you want to be able to see a change in a trend. And this one is not as clear as some of them. Some of them you'll see more like this, where it's really clear that the intervention changed the behavior. So anyway, we want to be more precise and more objective in terms of evaluating the magnitude of effect. And that's where effect size comes into play. Also, effect sizes are needed to summarize outcomes from single subject designs in meta-analyses. So we would like to be able to meta-analyze some of these multiple baseline designs, because these types of designs are used with more low incidence populations, and it's problematic for the clinician to make clinical decisions based on just one or two people. And so a meta-analysis, especially for single subject designs, could be really important. And we know that meta-analyses are emphasized in evidence hierarchies. It's that 1A study that you want to make clinical decisions. So why shouldn't we be able to do this even for single subject designs? So I just want to introduce you to some of the various effect size metrics that are used in this literature. And so these are non-regression based approaches, and they're called the family of non-overlap metrics. So as you're looking at research, I would keep this slide handy so that if a researcher is talking about PAND or PDO, you would be able to know that this is an effect size metric. And then there are plenty of resources out there on the internet, or you can contact me about how to interpret those effect sizes. But in this class, we're going to talk specifically about improvement rate difference, IRD, and percentage of non-overlapping data, because those are the two, at least at this point, that are most commonly used. But I have to say, in a lot of research, multiple baseline design studies that have been conducted before, prior to the last 5 years, you might not see any effect size metrics. But some of these are easy enough to calculate where you might consider calculating it yourself. So let's look at the improvement rate difference. This can be calculated by looking at the percentage of improvement between baseline and intervention performance. So what you have to do, and the second point is key here, you have to identify the minimum number of data points from baseline and intervention that would have to be removed for complete data separation. So that means that there would be no overlap between the two phases. Okay, so the points removed from baseline are called improved because they overlap with intervention, and the points removed from intervention are called not improved because they overlap baseline. So what you do is you subtract the percent improved in baseline from the percent improved in treatment. So that's a little confusing. Let's take a look at an example. So here is an IRD example. We see this is the baseline phase. There are 10 data points, and in the treatment phase we have 15 data points. Now, remember, if we go back, we have to identify the minimum number of data points from baseline and intervention that would have to be removed for complete data separation. So these two data points, if we remove that, then we'd have complete data separation, right? Because then the highest data point and baseline would be here, and the lowest data point in treatment would be this and this. And so there would be some distance between this one and that. So there would be complete data separation. And that's what you're looking for. So once you identify those 2 points, then you can calculate IRD, and it's fairly simple. So you say, what are the number of improved treatment points and improved baseline points? And I'll just go back up here for what that means. The points removed from baseline are improved. Points removed from intervention are not improved. So thinking about that, we have 14 that are improved because those are all improved data points, right? Better over the baseline. But we have 1 in baseline that is improved. That means it had to be removed, right? So then we see not improved. We had 1 treatment point right here that had to be removed. So that's considered not improved. And we had 9 baseline points that were not improved because they were lower than the rest of the treatment points. So then you total it up. And then here's a simple calculation. You say 14 over 15, so the improved over the total minus the improved over the total in baseline equals 0.93 minus 0.10 equals 8.83 or 83%. But then you have to interpret that figure. And that's where this comes into play. So according to Parker and colleagues, IRD ranges from 0 to 1. And what you're looking for is something at least, I would say, 0.71 or higher. And so with a 0.83, then that's large or very large effects. And so then you can feel pretty confident that it's the treatment that is causing the change in behavior. Okay? And if you just visually inspect this, you can say, okay, yeah, we see an upward trajectory change, and it looks like it's due to treatment. But here we have a figure and a way to interpret those data points. So that's really important. So what are the advantages of IRD? IRD provides separate improvement rates for baseline and intervention phases, and it has better sensitivity than PND, which is important. So that's why we're starting to see more researchers shift from using PND to IRD. It also allows confidence intervals, and we've seen it proven in medical research. Okay, some limitations. The conventions of calculation are not always clear for more complex and multiple data series. So if we have an AB, it gets a little hairy there. Baseline improvement, how that term is used is kind of misleading, because baseline, we shouldn't see any change. It should just be what the child or the client is doing without any intervention. We also know this is a fairly new concept, so it still needs more validation and some comparison to existing methods to show that it is indeed the best choice for looking at effect size in single case designs. Okay, so the next one, percentage of non-overlapping data, we're going to talk about because it was used, I think, more predominantly early on in this movement to include effect size metrics. So what we see is this is a little bit easier because we're just calculating the non-overlap between baseline and successive intervention phases. So what you do is you identify the highest point in baseline and determine the percentage of data points during intervention that exceed this level. So it's pretty easy to interpret, and it's a non-parametric statistic. So here's an example. So you identify the highest baseline point right here, and then you pretty much take a right angle and look and see what is at that point or below. All right, so here then you say, okay, how many points are at that point or above that point? So we don't even count the ties. So we say 1, 2, 3, 4, 5, 6, 7 out of 11 points. So then all you do is say 7 divided by 11, and that equals 64%. So if a study includes several experiments, P&D scores are aggregated by taking the median rather than the mean. Okay, the scores are usually not distributed normally, but the median is less affected by outliers. So this statistic, the higher the percentage, the more effective the treatment. So there are specific guidelines for interpreting P&D scores, and here is that interpretation. So P&D ranges from 0 to 100%. So really, you want this to be very high. So here, above 90% is highly effective. Fairly effective is 70 to 90%. Anything below 70, you wouldn't want to use for clinical decision making. So advantages of P&D, it's most widely used, at least at this point. It's very simple to calculate, and it's easy to interpret. But there is this overemphasis on the most extreme data point in baseline, and that could be problematic, because what if your child has one really great day out of 20? That's the highest baseline point, and then everything else is measured against that, when it might just be a fluke. So that's something to consider. There is no way to calculate confidence interval because you don't know the sampling distribution, and it's insensitive to powerful treatment effects. So just some things to consider when you're looking at the multiple baseline design studies, particularly those that you see, though these can be used with ABAB, and etc.